is my honor and pleasure to introduce my colleague, Professor Ahmed Donia. He will speak about the chronic allograft injury. Professor Donia.
Thank you. So my topic is chronic allograft injury. So over the last years, there was significant improvement in the short-term graft survival thanks to more understanding of transplantation, immunobiology, and more widespread immunosuppression and monitoring. However, unfortunately, this hasn't been matched with significant improvement of long-term graft survival. Therefore, chronic allograft dysfunction remains, along with deficit functional graft, one of the major barriers to graft longevity. Chronic allograft injury is defined as a state of gradual loss of graft function over time associated with proteinuria and hypertension, with traditional chronic tubular tissue changes, plus minus more specific chronic pathological changes, without clear apparent reason to explain for this progressive loss of graft function. Over the years, progressive loss of graft function acquired different names. So in this small city in Canada, the first BANF meeting used the term chronic rejection to describe chronic graft loss. However, about 4 years later, the same group realized that immunologic factors are not only the cause for progressive loss of graft function, and there might be non-immunologic reasons, and therefore BANF schema coined the term chronic allograft nephropathy, or CAN, which is perhaps the most abundant term still used till now. However, a decade later, BANF group realized that we misuse the term CAN, or chronic allograft nephropathy. We, nephrologists and pathologists, thought that chronic allograft nephropathy is a disease in itself. Meanwhile, it is only a description. It's like abdominal colic, and we have to investigate for the exact cause of this colic. That's why they realized that the use of CAN inhibited active diagnosis and therapy for chronic allograft function loss, and the group itself eliminated use of chronic allograft nephropathy and persuaded us to try to find the exact reason for this chronic loss. And in case we don't find any reason for this deterioration, and we have some chronic changes in pathology, then the term interstitial fibrosis, tubular atrophy, without evidence of specific etiology, is to be used. To diagnose chronic allograft injury, we have to exclude other causes that might cause progressive loss of graft function. So, chronic allograft injury is a diagnosis of exclusion. So, we have to exclude, for example, obstructive uropathy, graft artery stenosis, recurrence of regional disease such as focal segmental, graft infection such as BK virus, and the occurrence of late acute rejection, which is, although less commonly than acute rejection, which happens early after transplantation, yet it can occur especially with under immunosuppression and non-compliance. Again, chronic calcineurin inhibitor toxicity might be a cause of chronic graft function loss. So, chronic allograft injury is a diagnosis of exclusion. Because of the great overlap between chronic allograft injury and other causes, and because of the dynamic use and changing use of definition of chronic allograft injury, it is difficult to assess the exact prevalence of chronic allograft injury in transplant procedures. However, it is said that it might affect up to 90% of cases after 10 years of transplantation. A number of pathogenetic pathways and etiologies are postulated as possible reasons for this chronic allograft injury. In broad terms, there are subgroups grouped under either immunologic factors, which possibly occur early after transplantation, and non-immunologic causes, which might occur later after transplantation. So, examples for immunologic reasons that might lead to chronic allograft injury are poor HLA matching, repeated acute rejection cell. Recovery of acute rejection doesn't mean that this does not affect long-term graft survival. Ongoing subclinical immunological injury, preformed antibody-mediated chronic rejection. And here, if we find an evidence of active antibody-mediated chronic rejection, then this might go out of this description and might be treated differently. Also, chronic under immunosuppression and non-compliance. The other broad category of causes is non-immunologic category. Reduced nephron mass due to aged kidney, delayed graft function, small donor for big recipient transplantation, chronic tacrolimus or cyclosporin toxicity, persistent proteinuria due to any reason, and factors that culminate into atherosclerosis. And more recently, other factors that might cause non-immunologic chronic allograft injury, for example, FGF23, which is known in the cascade of CKD, mineral bone disease, and known with its relation to cardiovascular disease, might also be related to the presence of chronic allograft injury in kidney transplant patients. A report from our center trying to determine factors that affect long-term graft survival, and we concluded that aged kidneys, ethnic factors, primary immunosuppression, repeated acute rejection, and lower total steroid dose might be causes for short graft survival. And here is our patients and graft survival 10-year survival, and here we can find that patient survival is about 80%, while graft survival is about 65%. And among immunosuppression protocols used in our center, tag-based triple therapy had the best outcome. Chronic allograft injury is associated with histopathologic findings, and in fact, these findings predate clinical manifestations. In fact, by the time creatinine is going up, we are too late, and usually histopathologic findings are so severe to be reversed. Some characteristic but non-specific pathology, and in fact, chronic allograft injury affects the whole spectrum of kidney tissue, tubular tissue, glomeruli, and blood vessels. For glomeruli, this is the picture of what's called transplant glomerulopathy, which simulates membrane nephropathy. Vasculopathy with narrowing of the lumen and subentemy injury with myofibroblastic proliferation. And the more traditional, yet less specific, chronic tubular tissue changes. And despite that, glomerulopathy and vasculopathy are more specific, yet BAMF schema classifies chronic injury according to grade of tubular tissue chronic change. Usually, chronic allograft injury will show glomeruli which are negative for immunosuppressants. However, we have another parameter which might help in diagnosis, which is called C4D. As we know, antigen-antibody reaction will stimulate complement system, and this will cleave C4 and C2. So C4 will have C4B, and C2 will have C2A, and both of them will form a complex which is called C3 conjugate, which will activate C3, and cascade of complement activation will start. In an attempt to stop overactive complement, some inhibitory factors will try to transform this active form of C4 to inactive form, which is C4B. So despite that this is inactive form, yet its presence means that there was a struggle here, antibody reaction. So it is a marker of human rejection. And thanks to our pathology department, and this is C4D staining in immunohistochemistry, and as we know, the standard is immunofluorescence. So if mild form of staining in immunohistochemistry is present, this means strong result of C4D positivity. And as Professor Hussein mentioned, we care of diffuse linear, not granular, peritubular capillary C4D deposition. Electron microscopy also is helpful. Here we can find what's called multi-layering of peritubular capillaries. And in fact, this might help to differentiate MPGN from transplanted glomerulopathy. So the presence of this multi-layering is more with transplanted glomerulopathy. On the other hand, the presence of subtle inferior electron dense deposits are with MPGN. Also, we have to differentiate between chronic allograft injury and chronic active antibody-mediated rejection. Although both are active, yet if we diagnose classic chronic active antibody-mediated rejection, role of treatment might be there. And this is the latest BAMF schema. And although C4D was thought to be a very important factor to diagnose antibody-mediated rejection, so nevertheless, the latest BAMF schema complicated the issues more by coining what's called C4D negative antibody-mediated rejection. Therefore, according to BAMF schema, in order to diagnose chronic active antibody-mediated rejection, we have to have all these three features: morphologic evidence of chronic tissue injury, transplant glomerulopathy, vasculopathy, multi-layering on electron microscopy, evidence of struggle between antibody and vascular endothelium. And one of these evidences is the presence of C4D positivity. So if we have C4D negative and we have other evidence of this struggle, yet we have this point N. And the third pillar is the presence of positive donor-specific antibodies. So in order to diagnose chronic active antibody-mediated rejection, we have all these three factors present. And I think you have just seen one case of chronic active antibody-mediated rejection upstairs being treated with plasma exchange and IVIG, although it is a little bit debatable. Again, the traditional chronic tubular tissue changes are present in many diseases. So one important differential diagnosis is chronic calcium hepatotoxicity. And again, the presence of multi-layering and the transplant glomerulopathy will point to chronic allograft injury, while the presence of newly formed hyaline changes in the blood vessels will point towards the calcium toxicity. Some argument and criticism to Banff criteria in diagnosis of chronic changes, because Banff criteria didn't mention some chronic changes like mesangial sclerosis, FSGS, and this might be included in future Banff schema. So here, how could we prevent chronic allograft injury? By looking back to the possible causes of chronic allograft injury, we might find some ways to prevent this problem after transplantation. So, good HLA matching, proper immunosuppression, and this is a very, very elastic term. So, proper immunosuppression is very easy to be mentioned, but in fact, there are plethora of immunosuppressive protocols, and we don't know exactly what is the appropriate immunosuppression protocol, which is adequate enough to prevent rejection and lower enough to prevent side effects.